Moving on to the next presentation, I would like to invite Dr. Shweta Kedia. Dr. Shweta Kedia is one of the senior most neurosurgeons in our country, in India. She's recently been promoted as a professor of neurosurgery at the very prestigious AIMS Hospital and their Gamma Knife Center. Another interesting topic, if I may say so, she's going to talk on surgical complications in the management of OPLL. Dr. Shweta, over to you.
Shraddha, I think I have shared my recorded audio and video presentation, so they may just play this because...
Yeah, Saurabh.
Good afternoon all. At the outset, I would like to thank the organizers for having me here to share my experience on managing surgical complications of ossified posterior longitudinal ligament surgeries. Now, my talk is going to focus on cervical OPLL, and I would like to share some tips and techniques that we adopt to avoid surgical complications in OPLL surgery. We all know that it is a safe and effective way of approaching OPLL patients, yet it is associated with complications in the intra and the post-operative period. A beautiful paper by Bernstein published in Spine in November 2019 suggested overall complication rates of almost 21.8% in patients with cervical OPLL. And they also suggested that this complication rate was dependent on the type of technique that was being used for the patients. So the patients who were undergoing both anterior and posterior decompression with fusion had a complication rate reaching almost to 44%. In patients who underwent anterior decompression and fusion, the rate of incidental durotomy was very high. Even the non-neurological complications like pulmonary and cardiac complications were not uncommon. In fact, a paper from Nimhan's group also in Neurosurgery Focus in 2016 implied that the pulmonary complications are a pretty common complications in the patients with OPLL and should be carefully evaluated and monitored in the perioperative period. There are several factors that influences the surgical outcome and the complication rates, including the patient comorbidities. So for example, a patient of diabetes tend to have a poorer outcome. But what I'm going to discuss over here is the myelopathy severity, the OPLL severity, and the choice of technique and how it impacts the outcome in the patients. So here is a 54 years old male with a history of progressive spastic quadriparesis, hailing from Uttarakhand with no bowel bladder involvement and farmer by occupation, with the MRI and CT imaging showing gross OPLL. Now, what are the concerns in this patient? We all know that there is a high risk of complication rate. And what are the anticipated complications and what are the strategies that we would take to avoid those complications is what I'm going to discuss in the subsequent slides. Now, take a closer look at the CT scans. The preoperative sagittal CT scan and axial CT scans are very useful to study the K-line, the space occupying ratio, and the space available for the spinal cord. We all know that K-line is a marker for cervical spinal alignment and is helpful in determining the anterior based or posterior based approach for the patient. What we also know that hill or the plateau shaped and the different configuration of the OPLL, like the continuous, the mixed, the segmental, and the focal as proposed by Suyama, are indicators of OPLL severity. So a patient with K-line negative and hill-shaped OPLL is going to have an acute angle spinal cord compression, resulting in significant ischemic changes and will have a poor recovery potential. So this is what we need to keep in mind. Also, to have a closer look on the CT scan, what I want you to look at is the double layer sign. This is the ossified anterior and the posterior rim with a central hypodensity of the ligament. Now, this was first reported by Hida et al. And at this level, the dura is supposed to be diffusely absent, and there is a high chances of incidental durotomies in patients with double-layered sign has been reported. Almost 52% of the patients may have dural defects in this group. So if the patient is undergoing anterior surgery, we need to look for it. In MRI, we also need to look for the central and the foraminal spinal cord compression, associated degenerative spondylotic changes, and not to forget the myelomalastic changes. the T2 signal intensity has been classified to grade the severity of the myelomalacia, and in patients with grade 2 having intense T2 signal changes have the least recuperative potentials and poor chances of recovery. The role of dynamic MRI is not so much in this group of patients where there is a florid OPLL compression, but yes, in patients having significant clinical neurology deterioration, yet not so much observed on the MRI, should undergo dynamic MRI to localize the site and the level of compression. When we opt for an approach, the anterior or the posterior approach, we should also understand the inherent complications in that approach. And as I have been mentioning earlier, the incidence of durotomy in anterior approach is very, very high, reaching almost up to 35%, while it is only up to 6% in posterior approach. The nerve root palsies and epidural hematoma have also been observed in the anterior approach. This is a beautiful imaging I lifted from Min's paper in published in 2009, showing the herniating spinal cord through the defective dura mater observed after a follow-up period of few months in a patient who had postoperative neurological deterioration. Now, the posterior approach is a safe and effective technique, yet again not free from complications, and the patients may tend to have C5 root palsy very commonly. I remember my first patient of OPLL that I operated almost 8-9 years ago had torrential venous bleed and was undergoing, plan was to do laminoplasty, hinge door for this patient, and I had to convert it into laminectomy. I could not control the venous bleed that can be so torrential. Another of my patient who had deterioration in the postoperative, and we repeated the imaging, we found that there was a fracture of the laminoplasty hinge, and the patient was taken up for a redo surgery. Laminectomy and lateral mass fusion was performed in this patient, and patient did well postoperatively. What we need to understand when we choose the surgical technique, that the surgery-related complications escalates after revision surgeries, like in revision ACDF after posterior approach. The complication rate touches almost 63%. Now, C2-OPLL deserves a special mention. It is a very complex anatomic location. Anterior approach is very challenging, can lead to graft dislodgement. Patients may suffer from dysphagia, dysarthria, and therefore very surgically demanding. The posterior approach is easy and effective, yet may lead to paraspinal muscle atrophy and also cause destabilization of the spine and also associated cervical kyphosis. Sun et al. Classified C2-OPLL based on the C2-C3 segment ossification into 4 categories. And they also proposed the anterior controllable anti-displacement and fusion technique in a modified form for patients with C2-OPLL. So here they would resect the posterior wedge of the C2 body, and along with that perform the routine ACDF technique proposed by them, labeled as shelter technique, and which we have not used in our practices yet, but I think would be useful for patients with suffering from OPLL. Now, coming back to our patient, 54 years old male, is having signal intensity changes to almost grade 2 and also have associated degenerative changes. The OPLL at the C2 level is type A, but there is evidence of double dural layer sign, and therefore we opted for going posteriorly in this patient, performed a lateral mass fusion with laminectomy, and C2 lamina was undermined in this patient, was doing fine postoperatively. So to conclude, the preoperative planning and proper surgical technique definitely helps in minimizing complications in patients with OPLL, and obviously the team-based approach is the best way to go about it. Thank you.
Thank you, Dr. Shweta, for touching on finer aspects of OPLL surgery and making us more aware and telling us things which will help us in decision making in OPLL surgeries. So, ideally what we used to do is just the curvature, kyphosis, lordosis, and then decide regarding an anterior or posterior approach. What is your experience, and what do you think? Does it really make a difference which approach we choose according to the curvature of the spine?
Yeah, it matters. In fact, I think in one of the morning presentations as I was hearing, and we have started following that, is you should look at the whole spine and not just the cervical spine. So if you're looking,
I think we lost her.
Yeah. Are you there?
what
Dr.
would
Shweta?
be choosing? Yeah, do you hear me?
Yeah, I think we lost you in between. So
Okay.
you were saying
What
the
I
whole
was
spine
saying-
curvature.
Yeah. So you should be looking at the sagittal balance as a whole when you choose especially if you're choosing a posterior approach, if you're inclining towards the posterior approach.
So any comments or questions?
Madam, you are on mute. Dr. Anita, you're on mute.
Yeah, it's fine. Shweta, very nice presentation. Actually, what strategy we follow is that if the OBLL is 3 or more segments, we go from the posterior aspect and we do bilateral open door laminoplasty. You can do for bilateral or you can go for the unilateral also. And of course, you need to screen the patient. And like screening is one thing, but clinical examination will definitely do, that is equally important. And screening is really very important because sometimes they have the dorsal OPLL along with the cervical OPLL. So that is what.
True. So yeah. So since it's
and like after the approach complication. Yeah, after having this kind of complications from the anterior approach, we have started only doing the posterior approach, and we put the some graft like methylated acrylic graft that prevents the fusion of the canal, because ultimately you can't remove the whole of the OPLL in these cases.
We do still go for anterior approach, so carpectomy is still being followed here. But yes, if one of the discussions happen, if it is involving more than 3 levels, we would go in for posterior. There's some heroic surgeries that is being performed where they do carpectomy even for long segments, but that should be then facilitated and reinforced by the posterior fixation as well. Alone carpectomy anterior approach more than 3 levels is really not acceptable, but less than 3 levels, like 1 level, 2 level carpectomy is being commonly done.
Yeah, there's one more way. You can go posterior also, and you can drill from the posterior aspect, as you were saying the correctly. From the posterior aspect, you can perform by tilting the table and tilting the patient. You can go obliquely, and you can drill that also.
This shelter technique I was talking about, the anti-displacement, where they are they're not removing doing the carpectomy. So they're not removing the whole bone, partial resection. They're fixing up the screw, and when they tighten it with the curved plate, the body lifts up on its own, which I think is very useful. I don't have any personal experience on that. If somebody has an experience, maybe they can share their results. But I think it should be a good alternative in patients where there is so the worry the most concerning point on the anterior approach is the dura, which is adhered to the posterior ligament, and the chances of dural breach, which becomes very difficult to repair. And that is why these alternatives have come up. Hanji sir, please go ahead.
Dr. can we go ahead?
I think Dr. Prakash Modha raised his hand.
No, madam. I wanted to ask you about the anterior approach. In a case of OPLL, what is your experience? Is it devastating with a full of blood and CSF leak?
No, not really, sir. So luckily, I have had one patient which we operated in trauma center, because these patients usually, present after trivial trauma, they deteriorate and then they present to us. There's this one patient who had hematoma, epidural hematoma, because of the trauma as well. And to define the OPL versus dura was difficult. And so we had used flow seal and glue in this patient. Post-operatively, patient did well, but I would have preferred to leave the segment of OPLL then on this patient retrospectively. If I think we did take a chance in this patient. The rest of the corpectomy patients, I guess the case selection, I still remember there was one patient where I thought of going anteriorly. And in the morning of surgery, when I discussed the scan with my boss over here, he said, no, I think you should go posterior. Patient was intubated, but we changed the plan. We made the patient prone and we went in for posterior approach because he thought it would be a safer route. And that is how we have chosen our cases. So yes, other personal experiences.
Okay.